Good afternoon, and thank you for joining in to the conference. My name is Terry Mamounas, and I will present to you an update on genomic expression panels for chemotherapy decision making in early stage breast cancer. And I will try to focus my comments on actually 4 studies that were presented in the 2020 San Antonio Breast Cancer Symposium dealing with genomics for early stage breast cancer. And I will discuss the adjuvant chemotherapy benefit in ER-positive, HER2-negative patients by the 21G recurrence score, the results of the RxPONDER trial that were presented by Kevin Kalinske. Also a paper by Josh Sperano looking at the recurrence score, RS-Clin Score, which is a combination of clinical pathological characteristics and the recurrence score to individualize prognosis and chemotherapy benefit in ER-positive, HER2-negative breast cancer. I also discussed the MINDACT Trial Updated Outcomes presented by Dr. Cardozo, and then finish by presenting the results of the ADAPT trial dealing with the recurrence score and neoadjuvant endocrine therapy response for avoiding adjuvant chemotherapy. So the results of the RxPONDER trial, the schema which we see here, actually were practice changing, and it was a very significant development looking at the effect of the 21G recurrence score for patients with 1 to 3 positive nodes in predicting chemotherapy benefit. So women with a recurrence score of 0 to 25 and 1 to 3 positive nodes, either by axillary dissection or sentinel lymph node biopsy, were randomized to receive endocrine therapy alone or endocrine therapy plus adjuvant chemotherapy. And a total of about 5,000 patients were accrued in the study with a primary endpoint of invasive disease-free survival. The results were very interesting, as here we see the overall IDFS results for the overall population of patients. And as we can see, there was a small but statistically significant difference in favor of the chemoendocrine therapy group versus endocrine therapy alone. The difference was about 1.4% absolute. So small, but yet statistically a significant difference. But there was a menopausal status by treatment interaction. So when they looked at the benefit according on IDFS according to menopausal status, as you can see on the left side of the screen, there was no benefit in postmenopausal women, or the difference is really 0.3% and not statistically significant between the chemoendocrine therapy and endocrine therapy alone. On the other hand, in premenopausal patients, there was a significant and clinical significant benefit as well, as statistically significant, of about 5.2% difference here in favor of chemoendocrine therapy versus endocrine therapy alone. And if we look at the changes in differences in distant recurrence, it was only 0.3% for the postmenopausal and 2.9% in premenopausal. This is for distant recurrence. When they further looked at the results according to menopausal status and recurrence score value 0 to 13 or 14 to 25, it was very evident again that in postmenopausal women there was no benefit irrespective of the recurrence score, either 0 to 13 or 14 to 25. But in premenopausal women, there was a significant benefit both in 0 to 13 and 14 to 25. That benefit in terms of absolute terms was 3.9 for the 0 to 13 and 6.2 for the 14 to 25 group. But the actually relative reduction was very similar between the two groups. The reason for the higher absolute benefit here is that the risk of recurrence for these groups was a little higher because of the higher recurrence score. And also when they looked at the benefit according to menopausal status and number of positive nodes, for postmenopausal patients with 1 positive node, there was no benefit. 2 to 3 positive nodes, again, no benefit whatsoever. But in premenopausal patients, was about a 5% absolute benefit, both for the groups of 1 positive node and that of 2 to 3 positive nodes. And lastly, when they looked at overall survival, there was absolutely no difference in postmenopausal women, as you see here, but there is emerging a small difference that was statistically significant with a p-value of 0.032 for patients that were premenopausal. That difference in terms of absolute terms, as we see here, is about 1.3%. So obviously more follow-up is needed, but clearly the results of the study were practice changing. And of course, obviously the big question now becomes the benefit that we see in the premenopausal woman. Is it the benefit from cytotoxic chemotherapy, or is it in total or in part related to ovarian function suppression that occurs when these patients receive adjuvant chemotherapy? But very interesting results. The second paper by Josh Sparano dealt with the development and validation of a tool that integrated the 21-gene recurrence score expression assay and clinical pathologic features to individualize prognosis for distant recurrence and also prediction of absolute chemotherapy benefit in early stage breast cancer. And this endeavor essentially was to develop a prognostic and predictive marker of absolute chemotherapy benefit using patient-specific meta-analysis for about 10,000 patients that were included in the TAILOR-X trial, in the B14 trial, and the B20 trial. And as a prognostic factor, the focus on the data from B14 and the TAILOR-X. B14 was tamoxifen versus placebo, and TAILOR-X for patients that received neoadjuvant endocrine therapy alone. And the predictive factor, they utilized data from the B20, the chemotherapy data from B20, the chemotherapy and endocrine therapy benefit data from the TAILOR-X and B20. And finally, they validated their model in an external validation comparing the RS-Clin risk estimates for distant recurrence to a real-world experience of the CLALIT register from Israel in about 1,000 patients. Now, when they modeled the RS-Clin and compared it to just clinical pathologic factors alone or the recurrence score alone, clearly the RS-Clin, the combination of the two, provided greater prognostic information. And then once they developed the model, you can see here, for example, this is prognosis by RS-Clin based on the impact of tumor grade and tumor size in a hypothetical 55-year-old patient. And we can see for a clinical low-risk patient, not negative in this case, grade 1, grade 2, grade 3, we see the increase in risk of recurrence according to recurrence score, but you can see that the curve is much steeper for grade 3, that goes up to almost 35% for a recurrence score of 50 versus here 20% and here about 15%. And in the bottom, we see the effect of size. Grade 2 patient for all three cases here, but 1.5 centimeter, 2 centimeters, and 3 centimeter tumor, you can see again how the risk of distant recurrence increases with the recurrence score value in each category. And when they looked at the prognostic benefit of chemotherapy, essentially what they noticed again that it varied according to the grade of the patient, as we can see here within the recurrence score categories, and also tumor size within the recurrence score categories, as well as age within the recurrence score categories. And then they validated this in the CLALIT registry. And again, there was a high concordance in the rates of distant recurrence that were estimated by the RS-Clin, and they were observed in the CLALIT registry. You can see the correlation that was over, the lean concordance correlation was 0.96%. So this is a helpful tool to individualize the prognosis based on the recurrence score value, as well as the clinical pathologic characteristics, and more importantly, to predict better absolute chemotherapy benefit when chemotherapy is given according to all these factors. And then so the landscape of chemotherapy administration for ER positive, HER2 negative breast cancer with 0 to 3 positive nodes has evolved, as we can see. For postmenopausal patients, it's pretty straightforward, whether lymph node positive, 1 to 3 nodes, or lymph node negative, endocrine therapy all the way to recurrence score of 25. After that, chemoendocrine therapy. For premenopausal, it's a little bit more complicated. For lymph node positive, across the board, chemotherapy plus endocrine therapy, although here we're questioning whether with a recurrence score of under 25, some of this benefit is from ovarian function suppression. So that would be an alternative that would be discussed with the patient if they're adamant about not receiving chemotherapy. And for the lymph node negative patients, if they have low risk, recurrence score under 16, essentially with a low clinical risk or high clinical risk, endocrine therapy is appropriate. And then as we get to a recurrence score between 16 to 25, we start seeing some chemotherapy benefit for patients with a recurrence score 21 to 25, irrespective of clinical risk, and with a high clinical risk with recurrence score of 16 to 20. So here again, the RS-Clin can be used to facilitate the decision to give chemotherapy. And then another interesting paper was the updated results of the MINDACT trial, looking at outcomes and treatment benefits for patients that are considered low risk, stratified by the genomic signature. And again, this is the schema of the MINDACT trial. Basically, the primary endpoint of the study, the MINDACT trial took patients and categorized them according to the clinical risk and genomic risk. And for patients that were discordant, clinical low, genomic high, or clinical high, genomic low, they were randomized to chemoendocrine therapy versus endocrine therapy alone. And then the primary endpoint was to see that those patients that receive endocrine therapy alone, their outcome is above 92%, the lower part of the confidence interval. So they presented the initial results of 5 years, and in San Antonio, they updated for 8 years. And what they found in the 8 years is that the primary point still held. In fact, that the outcome at 5 years with the updated results was 95.1%. So the lower part of the confidence interval was 93.1. So it was higher than the 92% that they had set up. And also, when you look at the effect of chemotherapy for these patients with clinical high, genomic low risk, there was about a 26% benefit from chemotherapy, plus or minus 1.6. So we still see some chemotherapy benefit, and that is primarily seen in premenopausal women in an additional analysis that they presented in the past. So this is all the way up to 8 years. And then when they look at all 4 patient groups, the clinically concordant and clinically discordant, those that are clinical low and genomic low do very, very well, 94.7% at 8 years. The discordant groups, intermediate to some extent, 91.1 and 90.8. And the clinical high and genomic high actually does significantly worse now, 85.9% at 8 years. So excellent prognosis and low rate of events in all groups except for the clinical high and genomically high, although you can argue that there's a little bit of a difference between the clinical low, genomic low, and the discordant groups in the middle. And then when they looked at the group that was clinically low and genomic high, there wasn't significant chemotherapy benefit, but at 8 years, they see about 1.5% improvement. Very, very small, and not statistically significant. So in conclusion from that study, overall clinical low risk and genomic low risk both indicate excellent 8-year prognosis, especially for concordant clinical low and genomic low risk patients. The DMFS was 94.7% in that group. Stratification of clinical low into genomic low and genomic high shows for all endpoints a few percentage points decrease survival rates for genomic high. And like in clinical low and genomic high, the distant metastasis-free survival was 3.6% decrease compared to clinical low and genomically low patients. And randomization of the clinical low to genomic high to chemotherapy or not suggests only 1.5% difference, not statistically significant. But then randomization of clinically high genomic low, the difference, as I showed you, was about 2.6%. So there was a little bit of a difference, and primarily was seen in premenopausal patients. And the last topic was the results of the ADAPT trial, looking at neoadjuvant endocrine therapy as a means by which you can individualize whether patients can be treated with endocrine therapy alone or chemotherapy and endocrine therapy. So it was a little bit of a complex design, but essentially patients with N0, N1 with a recurrence score of under 12 were given endocrine therapy alone. But those with recurrence score of 12 to 25 that had a neoadjuvant endocrine therapy window and the Ki-67 dropped, they were to less or equal to 10%, then those patients were treated with endocrine therapy alone and were compared with the patients of recurrence score under 12. So these are the two groups for comparison to see if those that responded to the Ki-67 had as good of an outcome as those with recurrence score under 12. So clearly that's what the study showed. The primary endpoint was a 5-year IDFS, was 93.9% for the group of the patients of 0 to 11 and 92.6% for those that 12 to 25 that did not respond to endocrine therapy. That responded to endocrine therapy by decreasing the Ki-67. And the lower part of the confidence intervals met the primary endpoint of the study. So essentially they showed that it is safe to treat these patients with endocrine therapy and not add chemotherapy. When they looked at the results according to distant disease-free survival and overall survival, again, we see absolutely no difference as well. And when you look at the distant disease-free survival in the younger versus the older woman, again, that was the case. There was no difference in the premenopausal under 50-year-old, 50 or under, and in those over 50 years. So there is no benefit, no worse outcome either the younger or the older patients. And then that was true also for patients that were not negative, as well as those that had 1 to 3 positive nodes. And when they further looked at it according to the number of positive nodes, for recurrence score 0 to 11, there was no difference between any number of nodes, 0, 1, 2, or 3. But for recurrence score to 12 to 25, there was a little bit of a breakout of the curve for those patients that had 3 positive nodes, and a little bit less so for those that with 2 positive nodes. But the problem here is that the number of patients included in this category was very, very small, only 22 patients. So clearly, we can't say much about that, but certainly it appears that those patients that have up to 2 positive nodes can safely be treated with endocrine therapy alone if they had a recurrence score of 12 to 25 and they had Ki-67 response. So in summary and conclusions, the primary endpoint was reached. Patients with luminal breast cancer in 0 to 3 positive nodes it did equally well if they had the recurrence score of 12 to 25, as well as those that had recurrence score of 0 to 11. But 12 to 25, they had to have endocrine therapy sensitivity demonstration by Ki-67 drop. And again, they make the comment about those patients that had maybe 3 positive nodes that may not be appropriate, but again, the number of patients is very small. So this is all I wanted to update you from the San Antonio, and thank you very much for your attention. I'll be happy to participate in the discussion session. Thank you.